these are impressive. These are two pivotal studies. We have the DESTINY-Breast 11 and the DESTINY-Breast 05. The DESTINY-Breast 11 is in the neoadjuvant setting. Now the comparator is the European comparator, not the American comparator, which is dose dense AC followed by THP, and it truly showed improvement of pCR. What's really interesting about that study, no ILD significant that it was reported when you do it for a short period of time before surgery. That's very exciting to see. The DESTINY-Breast 05, on the other hand, took patients with high-risk features. So high-risk feature. I want to say today on our podcast, this is not the Catherine study population. This is not the TDM1 population. Because there's a lot of confusion about that.
Exactly.
Some people think that the DESTINY-Breast 05 is here to take the same population of the Catherine study to give them TDXD instead of TDM1. It is not. It is not. It's even a more high-risk population that then go on to receive the standard of care, which is TDM1 or TDXD. And it also showed improvement of outcome. I mean, astonishingly, you're seeing way above 90% disease-free survival. I mean, this is very exciting to see. We're really doing a lot of goods for those patients by using those new agents. The one worrying aspect about it, however, was the ILD when you use it in the adjuvant setting. And there was some death reported to the ILD, which is a little bit concerning. That's why you have to select your high-risk patients. These are the ones that really need it, right? So what do you think about that, Paolo?
No, I totally agree. I think, the idea of 4 cycles of TDXD and 4 of THP, even for patients with high burden in a neoadjuvant setting, is highly appealing. There actually was slightly more ILD in the anthracyclines arm than in the TXD arm. So I think overall we feel that it's safe to give 4 cycles of TDXD and 4 of THP. It's highly active. The population of DB-11 was mostly 90% node positive and mostly 75% or more receptor positive. It's hard to shrink these tumors, and to see over 60% PCR rates, I think is remarkable, especially now that we're starting to realize that carboplatin in this setting may not be as helpful as we were thinking. There is the NeoCAR HP trial, for which I wrote the editorial, so little promotional moment. Make sure to read the editorial on JCO, and there's going to be some thoughts about how to implement all this. But I do think carbo may not be so helpful. It adds toxicity. In this setting, I think THP and TDXD will become a standard of care in a neoadjuvant setting for patients with higher burden. And then for patients with lower burden, we may get away potentially just with THP. And I think that will be a critical part of the future, figuring out which patients may get away just with THP. We need to see the data from RFS, from CompassAir PCR, which will be critical. A more than 2,000 patients trial. We need biomarkers. We need HER2-DX to be validated. We need to think about TILs and ctDNA and all of this, even imaging biomarkers. Doing an MRI during treatment can help, or maybe a PET scan. There's so much. We just need all of these things to collide in a pragmatic way to treat our patients depending on the anatomic risk and the biologic risk. And I think we're getting closer. What do you think?
We are. And for me, one biomarker that is going to be the future is circulating tumor DNA. I mean, ctDNA is truly emerging as one biomarker that's super exciting, not only as an MRD test that people think it is being used for, but also to better escalate and de-escalate neoadjuvant treatment.